before I start the introduction. So, good afternoon, good evening, everyone, or good morning to all of you who are coming from different parts of the world to listen to our Prime session. So, today we have two speakers who is going to share with us some innovative ideas as well as research and study that they are working on. So, as I shared earlier, this is our last Prime for the year of 2025, okay? As we will be entering the hectic preparation phase of our conference, which will be happening soon in January in Yiwu, China. So, hope to see everyone there as well. So, I believe everyone do know our Prime session. Okay, we will have this Prime session every first Monday of the month. And this Prime session is generally a platform for us to share, network, as well as get feedback from the work that we do, mainly in medical education or health professions education. So without further ado, let me introduce you the first speaker, Dr. Michael Ko. So Dr. Michael Ko is a general surgeon and clinical associate professor at the Li Ka-shing Faculty of Medicine, the University of Hong Kong. And we get to know him because he visited us in NUS SANMED not long ago. So he also served as the director of MBBS program for assessment, a passionate educators and innovators. Dr. Ko led the development of Hong Kong first AI virtual bedside program in 2022, and an initiative that gained international recognition, including coverage by BBC World Service. So today, Dr. Michael is going to share with us his reflection on how the aging population, workforce challenges, and the impact of COVID-19 have shaped medical education in Hong Kong. And he will also discuss how innovation, particularly the integration of AI and virtual learning, can help to overcome some of these challenges and transform the way that we teach and train the next generation of doctors. So over to you, Prof. Michael.
Thank you very much, Shing. And can you see the screen here?
Yes, yes.
Okay, thank you very much. And yeah, it's always happy to speak to friends in US. So today my topic is medical education in 2020s, challenges, lessons learned, and the way forward. So a bit of a conflict of interest statement here because I'm actively developing some AI solutions for education, professional training in different industries with my friends. So we've got this startup company. So as mentioned, always pleasure to speak at the NUS. Thank you very much, Dr. Dujipa, for the invitation to this Prime session. And there are some other friends in NUS as well. So when we're talking about the challenges for medical education in 2020, outside 2025, the time that we are right in is a good time for us to reflect and to see what's our way forward because we are right at the middle of this decade. So the first challenge that we all know is the COVID-19 pandemic in 2020, which has put a lot of medical education activities on hold, especially when students are held in a lockup and they just can't come back to the medical facilities, not just in Hong Kong, but I'm sure that also happened in Singapore and other places in the world. So another challenge, apart from this episodic pandemic problem, is I would say this is a structural problem. It's a public health system facing with the problems of aging population, and also in Hong Kong in particular, we're facing a brain drain. A lot of professionals are going to abroad for pursuit of their professionals. So for medical schools, of course, we can increase the MBBS admission, but we're also facing a problem of lack of teaching staff, lack of teaching spaces, and lack of teaching materials, most importantly, our patients. So, of course, physically, we can expand our campus. However, how can we improve our students' learning experience? So the possible solution I came up with that time was, can we use technology? And I'll elaborate more on distance learning and artificial intelligence. So, as you all know, clinical skills are best taught face to face. However, for COVID-19 pandemic, it has rendered clinical skills teaching very, very difficult, especially when, of course, we can teach them in distance learning, but how can we overcome the obstacles of teaching our clinical skills or surgical skills or ultrasonic skills, for example, in terms of in the form of distance learning? So the usual surgical skill teaching, for example, is usually physical, face-to-face. It involves a real-time demonstration, practice, and then feedback by our tutors. And for ultrasound curriculum, we have incorporated point-of-care ultrasound into our MBBS curriculum as well. So there are a few components, including e-learning videos, so students will see how we manipulate the ultrasound probes. We do have face-to-face didactic live demo or interactive tutorials teachings. So students are taught to how to use the probes. At the same time, they practice on each other, and then the tutor will be present at the venue to give instructions, immediately give feedbacks. And at the time of pandemic, of course, we can't ask our students come back to the wards or to the hospital or to the university. And therefore, we have converted this surgical teaching into distance learning, of which the tutor was teaching at the school using different cameras, broadcasting how we do these clinical skills. Of course, those are really quite simple, suturing, knot tying, and incision making, this kind of simple skills. And we taught our students by distance learning, by using different cameras. And the students, they watch our live performance at home. And at the same time, we ask our students to practice the surgical skills in front of the camera from their home as well. So each and every student, as you can see on this picture, they were given a piece of synthetic skin, some suture materials, and also a set of instruments so that they can practice. And we can, as tutors, we can give immediate feedbacks. Of course, the communication was not as good as being face-to-face. However, this was the only way out during the hard time of COVID-19 pandemic. And similarly, adopting our experience from the teaching, the way that we teach surgical skills by distance learning method, we also start a distant learning ultrasound workshop for our students, of which, again, we broadcasted live from the campus where I was examining a surrogate patient. So again, different cameras focusing on my holding of probe. There's a camera on the screen and also another camera. The last camera should be usually focusing on the knobs on the ultrasound image. So not the ultrasound image, the ultrasound machine. So also in addition, our students, senior year students were also had the opportunity to borrow ultrasound device to practice at home. So they can scan their family, capture the normal anatomy of different organs of concern, like the thyroid, the kidney, etc. And they can send the image to us for discussion after the session. So we try to maintain as much interaction as possible during the distance learning workshop. Of course, post-pandemic, students were all back to our campus, and ultrasound or surgical teachings were no longer taught in distance learning. However, we still adopt a hybrid format of which students they can see a projection of the image on this bigger TV screen so that they can see how I perform ultrasound better on the screen, on the big screen. The next bit I would like to share about is our experience of using AI chatbot in bedside teaching. So I call it virtual bedside teaching. So conventional bedside teaching, as you all know, it's conducted in wards, but there are problems with conventional bedside teaching. For example, desired cases are not always available. Some patients might be too ill to be clocked by our students. Some patients might be discharged very early these days, especially, for example, my specialty, surgery. A lot of our patients were operated by minimally invasive methods and they were discharged the next day after operation. And the students never got enough chance to see our post-operative patients sometimes. And also, of course, COVID-19 pandemic, our students can't just come back and clock patient. And therefore, I see it as a catalyst to develop virtual bedside teaching. And therefore, we've developed this virtual bedside teaching platform by the use of chatbot. So it's a simple chatbot with a lot of different clinical scenarios, predefined clinical scenarios stored into the app, where the students can collect the clinical information just like clocking a real patient, but instead they were chatting in terms of typing in the questions with the virtual patient. And that was followed by case presentation and also discussion of that particular scenario. Of course, the prototype was developed during the COVID-19 pandemic. At that time, there was no artificial intelligence with this prototype, and therefore, as you can see from that screen cap, the feedback from the answers from the chatbot was quite monotonous, as you can see. And for example, if I ask, what's your problem? What's your reason that you see a doctor? The answers are all the same. So our feedbacks from the students at that time during COVID-19 pandemic was that chatbot was the response was very monotonous, and there was also issues with keyword identifications as well. So with artificial intelligence and generative AI, we have started our Banner Chats 2.0. It was developed in 2023 and rolled out in August 2023, incorporated with generative AI. And so the whole chatbot become more interactive. The answers were no longer monotonous. We can fine-tune the personality and the patient's preference as well. So at the back end, we defined the two roles of this chatbot, either a student or the teacher, where the students will be able to chat with a pre-trained GPT, and the teachers were able to add new records, to modify or delete existing records. So it's just like a real hospital with a new admissions, or patients might just discharge or might deteriorate or even died after the admission. So this is the application. After logging in, either going into the admin page where the teacher can amend the case, or can even see the student's view. And the students, after logging into the homepage, they can select the division, the ward, the case, and then enter the chat room. So this is the important bit for a successful chatbot. The most important part is the prompt. So we have to, apart from summarizing the symptom, we also have to instruct the generative AI, the GPT, to launch a role-playing game between the physician, the user, and the patient. And there's a prefix, main body, and the suffix. And the prompt information should be as detailed as possible, so that we should add a lot of other, sometimes you might see as irrelevant information, like patient's preference, patient's personal preference, or social history, etc., which is important bit of making the whole virtual patient looks real to our users. So it's just like writing a screenplay for the actors. So these are a bit technical. So this is the advice from my colleague in computer science. So there are some settings at the back end, lowering the temperature value to increase consistency of generated sentences, and also high top p-value, meaning that the GPT will be able to generate or to capture more, to generate more words possible. So as said, we can adjust the variations in personality. We can ask the GPT to be more aggressive or more timid. So it all depends on our prompt. So this is the interface of the 2.0 version. Still, we do not have the voice recognition, but it's a lot more improved. The output is less monotonous, more descriptions and variations every time that you talk, when you talk to the same, even to the same virtual patient, to resemble the real life scenario. So there are different conversation styles allowed in this conversation. And also it's multilingual. So we've tested on Chinese, English, and also some other languages from by my friends abroad. So we did a case control study to evaluate our students' performance after being taught by virtual patients, virtual bedside teaching versus conventional bedside teaching. And we found that at least for the clinical history taking skills in terms of different domains in the clinical history taking skills, they perform similar uh, in terms of the history taking skills. So advantages of virtual bedside teaching is that we can always tailor-made our clinical scenarios. We can adjust the difficulty of the clinical scenarios according to the student's need, and we can incorporate rare scenarios, uncommon complications for surgical procedure, for example, into the chatbot, which is not normally seen in wards, for those rare cases or rare complications. But we can still teach our students. And of course, we can also teach without geographic restriction. And therefore, in fact, I've co-hosted the virtual bedside teaching with NUS previously with my friend Serene Go, who is also the currently the consultant at the NUS, and we designed our own virtual patient. So Hong Kong, I've designed our own Hong Kong patient, and then Serene designed her own inflammatory bowel disease patient, so that the students from each university can cross-clock the virtual patient from another university. So it's like a joint discussion afterwards. So a lot of students, their comments from from this project, they gave quite good comments, in fact, good rating. And in fact, they treasured the opportunity to interact with the international peers in particular. So in addition, we also identified by asking our students about their experience with this conjoint virtual bedside teaching, that they found that the rating on the experience was was correlating well with the rating of the user friendliness of the chatbot, the identification of keywords, and also the interaction. So these are the three domains that makes a virtual patient a successful one. So I said, subsequently it was covered in local and international media. We even invited Serene to join us live at the press conference in Hong Kong as well. So of course, nowadays, as I've mentioned, in our chatbot, we mainly use GPT, but the next question is, can we use DeepSeek as the large language model in the chatbot? So we have developed the DeepSeek version this year, and we have evaluated our users' experience in the specialty clerkship students, of which they are the final year medical students. We asked them to clerk the chatbot A and B. So as you can see, 1 and 2 are created based on the chatbot A was a GPT, chatbot B was a DeepSeek, but they were created both by exactly the same prompt, the same condition. And patient 3 and 4, again, A and B. A is by GPT, and B is by DeepSeek. Again, exactly the same prompt and same clinical scenario. So we ask our students to blindly clock the patient and to give feedback on which chatbot is better. And we used a validated questionnaire, the chatbot usability questionnaire, and it was designed for general chatbot. So we've modified it a bit to make it more relevant to our scenario. And let me show you. This is the modified questionnaire that we've used. So there are 5 main domains, each with a positive and reverse scored questions. So at the end, 32 students responded to our study, and the mean score for GPT was 91, and the DeepSeek was 86.75. There was a statistically significant difference between the two scores. However, when you see exactly the score, the absolute score, both scored quite well, I would say. Is the lower one for the DeepSeek was still 86.7, which is not bad at all. But on the evaluation of the individual domains, as you can see, the three domains perform better by GPT in terms of the user friendliness, the explanation of clinical scenario, and navigation through conversation. GPT outperformed DeepSeek in these three domains in particular. So the question is, GPT or DeepSeek? GPT outperformed DeepSeek in general, especially in the three domains that I've mentioned. However, bear in mind that the study was performed in April to June this year, and it was during the initial launch of the DeepSeek at that time. And of course, there's possibility of further improvements in both LLMs. So I think further studies will be needed to see the updated changes. So further enhancements, I'll quickly show you a video here. I'll stop share and I'll show you a YouTube video here. Let's see. Share the YouTube video. Okay, here. Can you see the screen here now? So this is the latest version of the...
Well, it has been there for some time. Is it increasing in size recently?
Yes, it's definitely gotten bigger over the past few months. It wasn't so obvious at first, but now it feels quite noticeable.
But it's painless, right?
Yes, it's not painful at all. No redness or itchiness either.
So this is the chatbot that we have further developed. We've incorporated with voice recognition. We haven't added the avatar because of the cost issue, but it's of course technically feasible to add avatar. But something that I'd like to show you at the end is that after the case clocking, we can even have a assessment, AI generated assessment. So I can press on the assessment button, and then the whole chat history will be logged so that the teacher can see how the student asked the question, and there'll be scoring by the AI in terms of different things that the student has or has forgotten to ask. For example, I forgot to ask family history for thyroid problems, so I scored only C in that domain. So this is the latest development that we're doing. So I'll go back to this. Yes, go back to that slide. So further enhancement, we've incorporated voice recognition and also AI-powered assessment. So for other developments in AI in our school, including ultrasound image identifier, of which our students can upload their ultrasound image captured by their own portable device and upload to that particular the system program, and the system will give automated feedback to the students in terms of how good they capture the kidney image, for example, and they can also be directed to these e-learning modules online. So finally, just a few words on conclusion. A lot of people might say, what's the relationship between medical educator and AI? But let me extrapolate by applying the Boyce model for scholarship. Of course, we're not talking about the educator for Boyce model, but for scholarship, there are four components: discovery, integration, knowledge, and knowledge exchange. And for us, I'll say educators, we are like a chef, and AI tools are just foreign produced. So it is the matter how we can bring this foreign produced to the table and to improve the learning experience. For the chef, they improve the dining experience, and for us educators, we try to improve the learning experience, teaching learning. So it's just like making a perfect steak from those raw ingredients And for us, we use different AI programs, from the generative AI to the avatar generation programs, voice recognition programs, to integrate them into an AI teaching tool, and to create a better learning experience for our students. Of course, trials and errors, feedbacks from our peers, also important, as what I've been doing over the last 5 years or so. I kept asking our students feedback as well. And we, based on their feedbacks, we modify the program. So AI has improved the quality of teaching, efficiency of learning. Of course, we understand that there are problems with AI as well in medical education. But this afternoon, what I'm focused is how we can make a good use of AI to improve our teaching and learning. And as medical educator, most of us are not here to develop new AI algorithms, but we're here to integrate it into our real-time practice. So yeah, this is more or less that I would like to share this afternoon. And thank you very much once again to SenMed of NUS for the kind invitation. Thank you.
Thank you, Professor Ko, for your sharing, especially with regards to such an advancement in AI. So I don't see any question from the chat, but I personally do have a few questions. I do understand that here you are sharing about, the efficiency, how AI helps in learning. Can you share a little bit of challenges as well that you see when students are using AI?
The challenges, for example, initially when they were asked to use the chatbot, they do have some, like, they're afraid that we are replacing the virtual AI chatbot with the real life or the conventional bedside teaching, of which we reassured them this virtual AI platform will never replace the conventional bedside teaching, and especially we can't really train them to the human touch, the interaction between the patients and the students. So this is something that we reassured them that we're not going to replace it. And the second thing is that our students, some of them might have difficulty in but not difficulty. They have also got the tricks how to ask the AI virtual patient. For example, in our previous versions of the AI chatbot, some students cracked the way to how to reach a diagnosis by asking directly at the first sentence, "What is your diagnosis?" And then the chatbot gave the answer immediately without any other interaction, so the students already know what's happening in the virtual patient. So it was also something that we've learned through the experience.
Oh, thanks for sharing the processes.
Yeah.
I think there's two questions coming in. One is, I'll just ask the two questions in one
Okay.
go. What would be the single most benefit from your tool in enhancing students' learning? That is the first question. Second question is, I do see that you have conducted some kind of survey to understand student perception and comparing the different AI tools. Are there any plans to systematically evaluate the impact when they're in clinical learning or in practice?
Yes, thank you. So for the first question, the benefit, I think the most important benefit is really that we can incorporate the different clinical scenarios into the virtual bedside teaching. And for me, especially I'm a surgeon, we do have difficulty in recruiting patients for case clerking these days. And therefore, we rely quite a bit on virtual bedside sometimes. For those post-operative elective cases, they were discharged early. So I think this is, if I was asked to, the single most important benefit of this AI virtual patient, I would say I can teach my student without a need to recruit patients. So I can design my patient. I can also tailor-made a good patient for our students. So this is the most important benefit. And any plans to evaluate the impact in clinical learning and practice? I think we have evaluated the history taking skill. I think this is the easiest part because we can objectively measure their question asking ability or the history taking ability. However, I think in real life medical practice, it will be a bit difficult because history taking is just not it's not just the only component in clinical practice. History taking is only part of it, and there are lots of different like factors affecting how good our students become or how good they perform when they graduated as an intern or assistant intern. So a bit difficult, but yes, I'm sure that this is a very good question, Dr. Jujipa. I'll think about that definitely, how we can really systematically evaluate the impact on their practice in the future.
All right, thank you. I have just one more questions before we invite the next speakers. Because I see that the chatbot is still coming from a very English speaking avatar. So
Yeah.
do you have the intention to integrate more local language or more closer to the local context?
Yes, for information, we have tested
Yeah.
this on Chinese, Cantonese as well.
all
Cantonese
right.
is a bit, yeah, Cantonese is a bit tricky because there's no large language model that directly targets on the Cantonese audience. However, the output is like 90% or 95%, I would say, good to our usual like Cantonese communication, but English, Mandarins are all quite well translated.
All right. So you do have cases that which is more local or they speak in a local native
Oh no,
language.
each case has, at least for us, we've designed it identical case has function in English, Mandarin, and Cantonese.
I
So
see.
this, yeah, the student can choose which language to use, but English one
see.
is the gold standard.
All right. Okay, thanks for the clarification.
Yeah. Thank you very much.
So, all right. I think there's no more questions. Thank you so much, Michael, for sharing this interesting innovation. And oh, suddenly there's one question coming in. Perhaps we'll take one more because in the beginning we do have some technical glitch. How do you train the teachers to guide the students in the learning session using this virtual patient?
Yes, thank you very much for your question. Yes, we do have a workshop for our teachers to know what's happening, what's virtual bedside teaching. And we also designed it for each clinical scenario, we designed the PowerPoint for subsequent teaching so we can standardize the subsequent discussion so that each and every teacher will be using the same PowerPoint for that particular virtual patient. So that for them to go through the case easier.
Thank you. I hope that answers your questions. So thank you so much, Michael, for your sharing. I hope we will be hearing more advancements from this area because as I understand that AI has always been very fast forward. Yeah. So as an educator, we have to adapt the change as well. So thank you so much. Next, I would like to invite my colleague, Dr. Jillian Yong, to introduce the second speaker. Jillian, over to you.
Thank you, Dr. Michael and Shing for the earlier presentation. I would now like to introduce our next speaker, Srinidhi Prakash. Srinidhi is from Panimala Medical College Hospital and Research Institute. And today she will be presenting on a very interesting topic. So integrating environmental sustainability into medical education, insights from a cross-sectional study. So Srinidhi, over to you.
Yeah, I think my slides are visible and my audio is clear.
Yes, that's right. You may proceed.
So good morning, good afternoon, and good evening, everyone. I'm Srinidhi Prakash. I'm a medical trainee at Panimala Medical College Hospital Research Institute, India, and it's an absolute honor for me to be present here today. So as future healthcare professionals, we often talk about saving lives, curing diseases, and of course advancing medicine. So but today, let's all take a step back and ask ourselves, are we doing good enough to protect the very foundation of life itself, our planet? So this isn't just about addressing a knowledge gap among students. It's about shaping a generation of doctors who are conscious of their impact on the environment and determined to create a more healthier and sustainable future. So declarations, I don't have any conflict of interest and no external funding for the study. So before we move on, I want to take a step back and connect this study to a bigger picture, the Sustainable Development Goals. In fact, several SDGs are very deeply intertwined with the environmental sustainability, and let's look at a very few ones. SDG 3, which is good health and well-being. So this is our core as medical professionals. By integrating sustainability into medical training, we can better equip future clinicians to address the health effects of pollution, climate change, and also environmental degradation. Essentially, we are preparing doctors who don't just treat disease, but also understand its environmental traits. And then comes SDG 4, which is quality education, embedding environmental sustainability into our curricula, creates transformative learning. It's not just about knowledge, but about shaping responsible, eco-responsible, or environmentally responsible and future-ready healthcare providers who can think critically about planetary health. And then we have SDG 11, which is sustainable cities and communities. This one, may seem less obvious at first, but healthcare systems are major contributors to waste and carbon emissions. So educating health professionals to promote greener hospitals and effective waste management supports sustainable urban development and also climate resilient healthcare system. And then we have SDG 13, which is climate action. Finally, SDG 13 brings it all together, teaching the link between climate and health, helps clinicians understand, mitigate, and adapt to the challenges brought by climate change, both in practice as well as in advocacy. So as you can see, environmental sustainability isn't just an optional add-on in health education. It's essential, to achieve global health goals, sustainable development goals, and protecting the future of healthcare itself. So now let's bring this closer to home. How do medical students like me actually perceive environmental sustainability? What do we know about it? What are attitudes and practices surrounding it? So we conducted a study titled Assessing Medical Students' Knowledge, Attitude and Practices Regarding Environmental Sustainability and Its Impact on Human Health. It's a cross-sectional study. I conducted the study along with my mentor, Dr. Krishna. So this study was basically driven by one very simple question. How well are tomorrow's doctors prepared to tackle the environmental determinants of health and the environmental sustainability? So let's start with the question, how often do we think about the environmental footprint of our healthcare practices? So as healthcare professionals, our ultimate goal is to promote health and well-being. But here's the challenge. Environmental sustainability is no more a buzzword. It's an urgent, critical factor in safeguarding public health and tackling emerging challenges. Yet, surprisingly, most of our medical curricula don't emphasize sustainability. Isn't that ironic, considering the profound link between the environment and our health outcomes? Now imagine if every healthcare provider was equipped with the knowledge and skills to integrate sustainable practices into their daily work, from minimizing waste to reducing energy consumption in hospitals or even advocating for cleaner policies. These are tangible ways we could contribute. This is why integrating environmental sustainability into medical education isn't just decidable, it's essential. Future healthcare providers, people like us, need to be at the forefront of this transformation. Now let's move on by discussing the gap we are here to address. How many of you feel that environmental sustainability is adequately covered in medical education today? The truth is, it isn't. There's a significant gap, one that we can't afford to ignore any longer. And bridging this gap is crucial if we want to empower future healthcare professionals to incorporate sustainability into both clinical care and public health. But to do that, we need to start at the foundation, assessing where medical students stand right now. What do they know about sustainability? How engaged are they with these topics? This isn't just about awareness, it's about understanding their level of preparedness to tackle these challenges in real world. So with this insight, we can develop targeted educational strategies, one that equips medical students with the tools they need to create sustainable solutions in healthcare. And the aim of the study was to assess medical students' knowledge of environmental sustainability, their attitudes towards integrating sustainability in medical education, their practices in promoting sustainability in healthcare daily life. Finally, it aimed to propose strategies to enhance sustainability education in medical curricula. So this cross-sectional study was conducted across medical colleges in South India, targeting students from year 1 to year 4 with a total sample size of 450 students selected through convenience sampling. Data collection was carried out through 3 weeks using a structured and validated online questionnaire containing 3 domains: knowledge, attitude, and practices. The data were analyzed using descriptive statistics to summarize findings and inferential analysis, including the chi-square test and one-way ANOVA, to identify association between groups. So this is the basic statistics of how many students participated. We had around 60% to 76 female students, 40% 184 male students, and the mean age was 21.5 years. And you could also see the year-wise representation of the participants. So in our study, we found that when it comes to understanding environmental sustainability, 62% of students have a moderate understanding, while 20% have a high level of knowledge and 80% have a low understanding. Interestingly, we discovered that senior students, those in year 3 and year 4, tend to have more knowledge than their junior counterparts. So when we asked about the connection between sustainability and disease patterns, 45% of students recognize this crucial link, which is a promising sign. More encouragingly, 55% of students were aware of strategies related to the Sustainable Development Goals, indicating a growing awareness of global sustainability initiatives. However, only 37 students understood the environmental challenges unique to healthcare, a gap that we must address. And again, a remarkable 85% of respondents strongly agreed that sustainability is crucial in healthcare practice and education. Along similar lines, 78% of students believe that medical professionals have an ethical responsibility to address environmental issues. So this shows that the future healthcare professionals are already thinking about how they can play a role in preserving the planet while caring for our patients. What's even more promising is that 65% of students express their willingness to advocate for sustainability within the healthcare institutions. And additionally, 72% of students agree that integrating environmental topics into medical curriculum is essential. However, there's an important gap we need to address. Only 40% of the students felt confident in their ability to influence policy or system-level sustainability challenges. We found that while 50% of students regularly engage in sustainable behavior, such as minimizing waste and conserving resources, the remaining half are not as consistently involved. Even more surprising, only 20% of students reported occasional participation in voluntary sustainability activities. We also discovered that sustainable practices are more common in daily life, but are less prevalent in clinical settings, where only 35% of students reported making consistent efforts. So this raises an important question. Why is there a disconnect between personal and clinical sustainability practices? So in our study, 45% of students identified barriers like lack of resources or uncertainty about how to take actionable steps. Additionally, only 25% of students participate in institutional or community-based sustainable initiatives. So these findings highlight a very critical challenge. While there is awareness of sustainability, students face significant barriers that prevent widespread engagement. So our findings raise several important points that deserve deeper reflection. First, we noticed that senior students scored higher in sustainability knowledge, which suggests a clear gap in understanding between junior and senior students. This indicates a pressing need to introduce sustainability concepts much earlier in medical education, ideally from first year, so that students can build up a solid foundation that continues to grow throughout their studies. Despite the overwhelming positive attitudes towards sustainability, only 50% of students regularly engage in sustainable practices. So this highlights a significant implementation barrier. While they know it's important, taking consistent action in our daily and clinical practice remains a challenge. Another interesting point was the limited awareness of strategies behind SDGs. Only 55% of students were aware of these strategies, suggesting that we need to integrate global sustainability framework into medical training, equipping students with the knowledge to address larger systemic environmental challenges. So the low engagement in health-specific sustainability practices further underscores the need for more resources, targeted training, and also institutional support to ensure that we not only understand the problem, but also we feel empowered to make a change. And finally, it's clear that students are overwhelmingly supportive of sustainability in education, which presents a valuable opportunity for curricular reform. So by aligning medical education with sustainability goals, we can ensure that the next generation of healthcare professionals is fully prepared to integrate environmental sustainability into every aspect of the practice. The key now is to harness this enthusiasm of the students and create tangible pathways for students to engage, learn, and lead in sustainability efforts. So as we look ahead, embedding actionable sustainability skills in medical training is essential to empower students as true advocates for change. By combining theory with practical application, whether it's in the classroom or clinical setting, we can foster lasting sustainable behaviors that will carry through our careers in healthcare. But this can't be done in isolation. Collaboration among educators, policymakers, and institutions is key to ensure that sustainability is not a standalone concept, but a core part of medical education ecosystem. Furthermore, offering leadership opportunities for students will provide a platform we need to drive the systemic changes within healthcare institutions. When students are given the responsibility and autonomy to lead on sustainability initiatives, they will become the champions of long-term change. And finally, aligning medical education with global environmental priorities is crucial. So now is the time to create a curriculum that prepares the future healthcare workforce, not just for medical practice, but for environmental stewardship. Together, we have the power to shape a healthcare system that's sustainable, ethical, and also resilient for generations to come. So where do we look ahead from here? As we look ahead, it's clear that the way forward isn't just about adding a few sustainability lectures to the curriculum. It's about transforming how we think, how we teach, and practice medicine. So we need to build what I like to call eco-conscious, environmental eco-conscious medical graduates, professionals who integrate environmental sustainability and ecological responsibility into every dimension of the professional identity. So to achieve this, we developed a structured model, the Eco-Teach framework, after a lot of literature work, which outlines how educators can guide this transformation. So the framework breaks down to 8 domains, each one representing a vital role educators and institutions can play. The first E stands for embrace. Here, the educator is the integrator. Educators need to embrace sustainability as a core component of medical teaching. That means integrating environmental concepts not as an optional extras, but as essential themes across disciplines and clinical contexts. Then we have C for correlate. Here, the educator is the contextualizer. We must connect the dots between sustainability and clinical relevance. For instance, linking air pollution to respiratory diseases or climate change to vector-borne diseases. So this helps students see sustainability isn't abstract. It is directly linked to patient outcomes. O stands for orchestrate. Here, the educator is basically a mentor. Educators act as mentors who orchestrate the stewardship, who foster stewardship. This means fostering values of responsibility and reflection, encouraging students to think not just about treating illness, but about preventing them and also saving the environment. Then T is for transcend. Here, he or she, the educator, is the innovator. Here, the goal is to transcend traditional teaching methods, innovate, redesign curricula to include experiential, case-based, interprofessional learning, imagine simulations or community-based projects that bring sustainability to life. Then anything without evaluation is of no use. So E for evaluate, the assessor. Here, the educator is the assessor. We can't improve what we don't measure. So educators should develop assessments that actually test sustainability, knowledge, skills, and behaviors, not just theoretical awareness. A for advocate. Here, the educator is the ambassador. Educators should lead by example as ambassadors. That means advocating for institutional and policy level changes that promotes greener healthcare practices in education system. We have C for connect. Here, the educator is the collaborator. Sustainability is inherently interdisciplinary and multidisciplinary. Collaboration with engineers, environmental scientists, public health professionals, and policymakers is essential to co-create meaningful learning initiatives. And finally, H for hypothesize, the researcher. And finally, research ties all together. We need to generate and apply evidence on what works, evidence-based strategies for effective sustainability teaching and curriculum models. So the Eco-Teach framework isn't just a very catchy acronym, it's a roadmap for transforming medical education. It envisions a future where environmental sustainability is not a side note, but a core value shaping every medical graduate's identity, practice, and purpose. By embedding these principles, we move one step closer to producing a generation of doctors who just don't heal people, but the planet itself. So now that we have seen how educators can foster sustainability through eco-teach framework, let's shift our focus on what this transformation means for us, the learners, the future doctors. So what kind of graduates we are hoping to nurture? So here we outline 8 roles of an environment and eco-conscious medical graduate, a model that envisions the kind of healthcare professionals the world needs today. First, environmentally responsible clinician. So this role reminds us that sustainability begins right at the bedside. As clinicians, we must deliver safe, effective, and low-carbon care, integrating environmental risk assessment and resource stewardship into diagnosis, treatment, and prevention. Even small choices like minimizing single-use plastics or optimizing energy use in clinics can make a huge difference. Next is ethical and ecological steward. This is about extending our ethical responsibility beyond patients to the planet itself. The same principle of do no harm applies here, not just to individuals, but to the ecosystem, the environment, and the planet. It's an expansion of our professional concepts. Then we have system-aware practitioner. Health doesn't exist in isolation. A systems-aware practitioner, we need to understand how health is influenced by complex ecological and social systems and how healthcare systems themselves can become more sustainable. It's about seeing the big picture and making informed choices at the systems level. Then planetary health advocate, of course, this role calls us to move beyond the clinic and into advocacy. So it's about promoting policies and behaviors that address environmental determinants of health, from air quality, water safety to system and urban design. So advocacy is where our medical voice becomes a tool for change. And then we have sustainable scholar and innovator. Here, the focus is on generating and applying evidence for sustainable healthcare practices, whether it's researching, conducting projects, or evaluating hospital carbon footprints. This role encourages innovation grounded in science. Next, interprofessional collaborator for sustainability. Sustainability isn't a solo act. This role highlights collaboration, working with engineers, environmental scientists, policymakers to co-create greener healthcare system. The best solution happens when medicine and other fields come together. And we have educator and ambassador. As educators, where formally or informally, we all have the part to model sustainable behavior. This role is about fostering environmental literacy among peers, communities, etc., leading by example and inspiring collective responsibility. And finally, the reflective lifelong learner. Being eco-conscious is a journey and it's not a checklist. As reflective lifelong learners, we must continuously evaluate our practices, adapt them to emerging evidence of environmental health. So the goal is to keep evolving, both personally and professionally, as the science and challenges evolve. So together, these 8 roles represent a holistic vision of what a 21st century, the next generation physician should look like. Someone who heals not only individuals, but also communities, ecosystem, and the planet itself. In essence, environmental responsibility becomes part of our medical identity, not an extra course or module, but it should be a mindset. So of course, vision without action is just a dream. That's why we wanted to bring these ideas into practice through our ongoing project titled Meaningful Learning, Engaging Medical Students with Planetary Health Through Humor. So our aim here is to assess how effective memes can be as microlearning tools in teaching planetary health. Because let's face it, today's learners respond best to creativity, relevance, and humor. So it's a small but meaningful step in transforming medical education, one me, one message, and one eco-conscious doctor at a time. So thank you so much for your patient listening. I would like to take up the questions and feedback.
Thank you, Srinidhi, for this really nice presentation. I can see that a lot of work has been put into it and very nicely fleshed out. For our participants, do feel free to put your questions in. We have 2 questions at the moment, one from Astrid. Right. Can you provide some insights on how to structure the eco-conscious medical education in the different levels of education? For example, what we teach for first years versus 4th year students.
Okay, that's an amazing question. So this is basically the idea behind integrating environmental sustainability. As have been stressing upon throughout the talk, that it shouldn't be just a single module. given at one point in time, but it should be integrated vertically along the years as the student moves on from first year till the final years. So maybe in the first year, you have here in India, we have the anatomy, biochemistry, and the physiology. Right. So they can have a separate module which is going to basically introduce them to what is environment sustainability. Because here, what I think is a direct connection between these preclinical subjects and environmental sustainability may not be possible. So you just give them a thorough overlook of what is environmental sustainability and how it is important for health professionals. But as they move on to the clinical years, right? So there we integrate it according to the subject wise. For example, when they go for the clinical bedside teaching, which I've already mentioned, you can say how they can, preserve the resources, thoughtful prescribing, and all this that can be done for the final year students. So this is how, according to and for example, in the third year, we have a subject of community medicine, which will be very much relevant to this particular topic, and most of the module can be imparted in this year. The third year, or in the community medicine subject, or they can have something like public health. If your med school has, you can incorporate it as a part of public health as well.
Thank you. So really building on known previously and also integrating it with the content or the curriculum that is already currently in place. All right, thank you. So another one is from Wong, from Dr. Wong. Hi, Doctor. Thanks for sharing. May I know what is the survey on knowledge and attitude adapted from? Any validated questionnaire used?
Okay, so we developed our own questionnaire. We validated it, pre-testing, and all the testing was done. And then we, around 30 students, we connected a pilot, and then we imparted the questionnaire to a larger population. So it was our developed questionnaire.
Thank you. So it was a self-developed questionnaire, then you validated it as part of your study. All right. Okay. For Dr. Wang, I hope this clarifies your question. If you have any further questions, feel free to put it in the chat. And then lastly, from Dujipa, after training, how do we know whether they actually apply what they learned? Are there any incentives for students or faculty to be eco-conscious?
Yeah, that's an amazing question. So, as I already told, we are in the process of, the project Meaningful Learning, where we are imparting planetary health education via memes. So, before we start, we are again developing a questionnaire which will be given to the students before the intervention. It will be again testing their, knowledge, attitude, and practices. A different questionnaire from the one we used for the survey, and then we will have the intervention, which is around 2 to 3 months. Where every single day they will be receiving one meme technique, which is going to have the concepts of planetary health. And post that, we are going to be again conducting the post test with the same questions and compare the pre and post survey. And to the next part of the question, are there any incentives for students or faculty to be eco-conscious? Okay, so for our study, we are planning to give them a kind of e-certificate for participating in the study and tell them they are environmental and eco-conscious medical graduates. Just a small certificate, but yeah, we should think upon it. That could be kind of attractive. We will think about it, the incentives.
Thank you, thank you. Definitely, there is way more than the cert when it comes to being eco-conscious, because it's also about planetary health. We definitely look forward to receiving your publications or hearing from you about the findings from your interventions that you are including. Okay. One final question from Wong. Just wonder, can we view the validated survey online? Any links available?
Amazing. So this study we conducted, I think last year, and I presented a study for the APMEC 2025. And now currently we have written the paper and it's under review. And I think once it's out, we'll be able to see it online along with the validated question.
Thank you. So we look forward to receiving the news whenever you get your paper published, and so that we can look at the results and the surveys online as well. So yeah, please share it with us once you have your paper published. So thank you once again to Srinidhi for the really important research that you have done. And I'll pass it over back to Dr. Shing to wrap up.
Thank you, Julian, and thanks to both speakers who have shared with us a lot of interesting ideas and study as well. So we hope to see you in our next prime session, which